Derm pathology, skin cancer. Basal cell carcinoma, squamous cell carcinoma, and melanoma. These are our common skin cancers that you need to know. I'm going to start off with melanoma because basal cell and squamous cell are somewhat harder to differentiate from one another, and melanoma is very easy. Okay, so first off, melanoma is the scariest. Okay, it carries the most significant risk for metastases of the skin cancers. It has an S100 tumor marker positivity. So if you see S100 positivity, they're probably talking about melanoma. And what they want you to know is kind of the fact that melanoma grows in depth rather than in length, okay? So it's not going to grow outward all around your skin. It's going to grow deeply. And that's why it carries the largest risk of metastases, because it grows very deep. And that correlates with the risk of metastases. Now, what they want you to know to identify a melanoma is 5 things, the A, B, C, D, and E's. Asymmetry, border irregularity, color variation, a diameter that's greater than 6 millimeters, and evolution over time. Does it change over time? Now, for me, did I remember the A, B, C, D, and E's? No. Was I able to spot out melanomas? Yes, because they're very easy. Take a look at what they look like. They just look irregular and they're dark, okay? It's something that you will notice for melanomas, okay? You can be able to figure them out very easily, okay? Now, what they want you to know also is that it's often driven by activating mutation in the BRAF kinase. Okay, BRAF kinase V600E mutation is what the mutation is. So you have to know that it's BRAF kinase mutation. Specifically, the mutation is a V600E mutation. They want you to know that for melanoma. Okay, easy, straightforward. Now, treatment is going to be excision with appropriate wide margins. You have to get all the margins. All right. Now, melanoma, because it's S100 tumor market, you know that it's going to be derived from neural crest cells, right? As we know, our melanocytes are going to be derived from neural crest cells. And so that's why it gives us an S100 tumor marker positivity. Lastly, they want you to know the color variation in melanomas. I remember this question, and honestly, to me, it's not high yield, but if you want to get this question right, might as well tell you it. So if it's white or gray, that means that the CD8 T cells have destroyed melanocytes. Then it will turn red, which tells me that there's vessel ectasia and local inflammation. Finally, the melanoma will turn brown and black, and that tells me that there's an advancing malignant melanocytes, okay? So overall, that's kind of the progress of the color variation in melanomas. White and gray, then to red, then to brown and black. And that's what each one of the colors means. Now, what you should know is that for people that are darker skin colors, Black people will have an increased risk of melanoma on the palms and soles because they have a decreased amount of melanin in those specific areas. But overall, they have a decreased risk in melanoma overall because of their darker skin tone. Okay, so keep that in the back of your mind when discussing melanoma. All right, so that's very easy. That's melanoma straightforward. Now let's talk about basal cell versus squamous cell. Okay, so first off, basal cell is more commonly on the upper lips and squamous cell is more commonly on the lower lips. But that's not really the highest yield thing. I thought it was going to be helpful, but it wasn't too helpful. The second thing that you should know is that sun exposure is the strongest risk factor for predisposing yourself to skin cancer. Okay, that's obvious. Now, let's kind of go through basal cell and squamous cell. I'm going to start off with the quick summary of what you need to know, and I'm going to end off with the quick summary of what you need to know. First off, basal cell carcinoma, what you need to know. Top lip, you're going to see a translucent, pearly type of mass on gross appearance with telangiectasias and a pink papule. So let me start that. Translucent, pearly mass with telangiectasias, okay? And it's going to be a pink papule. So translucent, pearly, pink papule with telangiectasias. If you see that, then you know basal cell cancer. That's gross appearance. Now on biopsy for basal cell cancer, it's going to be basophilic and peripheral palisading. So you can see basophilic and peripheral palisading cells or nuclei. All right, so that's basal cell cancer in a summary. That's what you need to know. Squamous cell carcinoma is going to be common on the bottom lip, right? On gross, you're going to see scaly pink nodule, a scaly, rough pink nodule, okay? And it could be actinic keratoses, which is a predisposing factor to squamous cell carcinoma. Scaly pink nodule, they'll say scaly, okay? Scaly is high yield for squamous cell carcinoma. Now, biopsy, you will see eosinophilic keratin pearls. Remember, keratin pearls are going to be seen on squamous cell. Any type of squamous cell cancer, keratin pearls. Eosinophilic keratin pearls with dysplastic keratinosis, okay? Or dysplastic keratinocytes, sorry. So that's what's biopsies for squamous cell. So basal cell is on gross, it'll be translucent, pearly, pink papule with telangiectasias. And on biopsy, you'll have a basophilic and peripheral palisading nuclei. Squamous cell is going to have on gross scaly pink nodule that's rough. On biopsy, it'll be eosinophilic keratin pearls with dysplastic keratinocytes. Okay, now let's dive into basal cell carcinoma. So basal cell carcinoma is the most common type of skin cancer. Once again, it's found in the skin exposed areas of the body, usually the face, and it can present, once again, with a pearly nodule, pearly pink nodules with telangiectasias, okay? Very important to know. It's going to arise from the epidural keratinocytes, and it will have rolled borders at times. So if you see rolled borders, that's associated with basal cell carcinoma. Now, the basal cell tumors have palisading aligned nuclei, okay? So palisading with local growth. Keep that in the back of your mind, peripheral palisading. Next is going to be squamous cell carcinoma. Squamous cell carcinoma is going to be rapid growing, okay? Usually associated with immunosuppression or chronic non-healing wounds. Now, what they want you to know is that it's going to commonly appear on the face, right? The lower lips, the ears, and it rarely metastasizes, just as like basal cell rarely metastasizes. But ulcerations is common and key. You will see an ulcerative red lesion. So if you see ulceration, it's going to be squamous cell. So squamous cell looks really nasty. And there's something known as actinic keratoses. Actinic keratoses is pre-malignant lesions due to sun exposure that can progress to squamous cell carcinoma. And we talked about it. It's going to present with a central scale with rough sandpaper-like texture. Remember, it's rough, it's scaly, okay? And there can be flaky dots on the forehead, which is known as actinic keratoses. That's going to be kind of a presentation, flaky dots on the forehead, all right? And it's a risk factor for squamous cell carcinoma. Lastly, you're going to see keratin pearls, eosinophilic keratin pearls with dysplastic keratinocytes. So that's it. That is our skin cancers. Those are our high yield associations. If you have any questions, let me know.